Now today we'll be discussing about so many X-rays. Now this is typical X-ray chest, and this is basically what we need to see is very easy. In this, a large amount of thorax is visible and much part of the abdomen is also visible. So this is all abdominal, this is diaphragm, and this is diaphragm. So here we can very nicely make out the heart shadow, and this is the pulmonary artery. Now we can very clearly see that pulmonary artery is not very dilated or not very large, because large pulmonary artery will be seen in pulmonary artery hypertension. See, it's very narrow. If it is more than 1.7 centimeter, we call it as pulmonary hypertension. Prominence of pulmonary artery will be labeled as pulmonary arterial hypertension. Here the pulmonary artery is not very prominent. Other things which are the one of the most important things are, we should always see the apex. This is the apex of the LV. This all portion is left ventricle, when left ventricular free wall, and the lowermost and the outermost part of the left ventricle over the precordium is called apex. So this is all apex. This is apex, where we can see actually apex bit. It has to be medial to mid clavicular line. So this is the clavicle and this is the mid clavicular line. It has to be midline to the mid clavicular line, and in the 5th to 6th intercostal space, in 5th intercostal space. So this is medial to mid clavicular line. The most important thing to remember is the apex moves in two conditions. There can be either volume overload or there can be pressure overload. So in the volume overload, there will be more blood flowing into the left ventricle. So more blood will be accumulated in the left ventricle, and this apex will simply get shifted to the lateral portion of the thorax. So in which condition we'll see more blood is where there are regurgitant lesions. Regurgitance means there can be mitral regurgitation. So there will be more blood flowing from left atrium to left ventricle in aortic regurgitation, so that there will be more blood flowing from the aorta to the left ventricle. There can be patent ductus arteriosus. So patent ductus arteriosus, it is very simple. The patient must have continuous machinery murmur. If there is continuous machinery murmur, you can suspect patent ductus arteriosus, and in patent ductus arteriosus we will see the differential cyanosis. So these two things are very easy. There should be continuous machinery murmur and there should be differential cyanosis. Differential cyanosis means in upper limbs there will not be any cyanosis, but in lower limbs toes they will be cyanosed because of the reversal of patent ductus arteriosus, or because of the patent ductus arteriosus. The third thing, so there can be a rupture of sinus of Valsalva, which is pretty rare. So aortic regurgitation, mitral regurgitation, patent ductus arteriosus, VSD, that is ventricular septal defect or atrial septal defect. In ventricular septal defect, there will be midline pansystolic murmur flowing from left ventricle to right ventricle, and it may go from right ventricle to left ventricle if there is reversal of shunt. And in ASD, where you do get cyanosis, and in that case you can see the fixed split of S2. So these are very typical features of the regurgitant or volume overload conditions, which can actually shift the apex to the lateral side. So if there is LVH, or if there is a pressure overload, for example in hypertension, there is no fluid overload, there is only pressure overload. There is high pressure against which the heart has to pump. The aortic stenosis or left ventricular outflow tract obstruction. So here there is no volume overload, there is actually a pressure overload against which the heart has to pump. In that, the patient will have LVH, that is left ventricular hypertrophy, but the apex will simply stay here only. So the patient will have concentric LVH. There will not be volume overload, so the apex will not get shifted. So you must know this: if apex is midline to midclavicular line, it means that the patient does not have severe MR, or the patient does not have severe AR, or the patient is very less likely to have PDA or VSD or ASD. So for VSD, the patient must have cyanosis. For the ASD, definitely the patient may have cyanosis. For patent ductus arteriosus, the patient will have usually differential cyanosis and continuous machinery murmur. For VSD, the patient will have pan-systolic murmur, which will be best heard in this parasternal region, which will be radiating from the left ventricular to the right ventricular. In MR, it's very simple. In MR, most of the time the patient will have a pan-systolic murmur, and the murmur usually radiates to the left side axilla in 90% of the cases. So radiation to the axilla, the axillary murmur which is radiating to the axilla, shifting of the apex toward the lateral side, outer side, and a pan-systolic murmur will help us to have diagnosis of severe MR. Whereas severe AR, the patient will have this murmur which will be best heard on the aortic area, neo-aortic area, and there can be radiation of this murmur from this aortic area towards the left ventricle, and the apex will be definitely shifted out and down. So with this knowledge we can see other things. So you have to always look for the apex, and you have to find out where is the apex. Now when we go for the other x-rays, in C, this is the second x-ray. Now we can very clearly see that this is the mid clavicular region, and see the apex. This is LV and the apex is going here. It is pretty down and out, it is going outside the mid clavicular line. So this patient is very likely to have MR or AR or PDA or VSD or ASD. Now VSD, ASD, PDA, they are very rare. MR, that is mitral regurgitation, is extremely common. It is one of the most common valvular pathology, especially in females. And AR, that is aortic, it is usually seen in elderly patients and it is seen in male patients more. MR, mitral pathology, is very common in female patients and usually in young female patients. So MR, there will be pan-systolic murmur and there will be radiation of this murmur towards the left-sided axilla. Whereas aortic regurgitation, that will be best heard over this neo-aortic area, which is on the right side around fourth intercostal space, the parasternal area, and this murmur will be radiating from this neo-aortic area towards the left ventricular, because this is the area of aorta. This is aortic knuckle, and from here you have aorta which comes and then goes down as thoracic aorta and then abdominal aorta. So this particular patient had severe MR which had caused large volume overload and dilatation of this left ventricle and shifting of this apex to the downside and lateral side. So this patient particularly had MR, severe MR. Next is when we see this I wanted to discuss this X-ray first. Now in this X-ray, what we can see, if you want to, for this is the midclavicular area, so because this is the clavicle and this is the middle of the clavicle, so if you put a line, the apex is still medial to midclavicular line. So if it is not crossing, but if you can notice, this is the left atrial area, this is the left ventricular area, this is left atrial appendage area, which is pretty straight. Means there looks to be left atrium hypertrophy or left atrial enlargement. Now why will there be left atrial enlargement? See, left atria can be enlarged in two cases: either there is pressure overload or there is volume overload. So if there is significant pressure in the left ventricle, this pressure will be reflected to the left atrium, or if there is significant amount of volume in the left ventricle which is getting reflected into the left atrium, then the patient can have left atrial enlargement. So if there is large amount of blood which is flowing from left ventricle to left atrium, it means कि left ventricle should get more blood. It means कि the patient's apex should be down and out, but the apex is not down and out. It means that there is no volume overload, it has to be pressure overload. That is the reason why the left atrial enlargement is there and apex is not yet shifted out. It means it is a pressure overload. So it's very simple. Left atria, left ventricle, they are connected through a mitral wall. So there is only one possibility, and that is severe MS, because mild to moderate MS will not cause this much of pressure overload. So this particular patient had severe mitral stenosis. So only on the basis of apex beat or apex we can have an idea what underlying pathology the patient may have. If you look very carefully, see the pulmonary trunk, it looks so dilated. See on this area also there is pulmonary trunk prominently significant. If you zoom in, you can see this pulmonary vasculature is pretty prominent. So the patient had severe MS causing increased left atrial pressure. Now this left atrial pressure will increase the pressures in pulmonary venules, and in pulmonary venules will increase the pressure in the pulmonary arteries. So this patient had pressure going back from mitral wall to left atrium to pulmonary veins to these pulmonary arteries. That was the reason why this patient had severe pulmonary arterial hypertension because of the severe MS. So this is very interesting, and how we can find out on the basis of X-ray what the patient may have. This is one of the